Assalamu alaikum ji. This is a patient that I did last night. This is a 65-year-old female, known case of diabetic nephropathy, on dialysis, hypertension, presented with severe shortness of breath, as well as typical central chest pain radiating to both shoulders. She was admitted and an emergency dialysis was performed, and the results of troponins were awaited, and when they came out, there were two sets sent for tropi, and the drops were 3000 and then the next was 3400. So it was decided that the patient would go for a dialysis after the procedure. So she was brought to the cath lab, and this is the first view that I took. I went through femoral because of the deranged creatinine, and it shows moderate to severe disease in the sizable obtuse marginal branch, but you can clearly see that there is severe osteal disease in the LAD as well as ramus intermedius. In the spider view, you can clearly see the ostium of the LAD severely calcified and almost subtotal obstruction from here. And this is the right shoulder view, and you can see that there is severe osteal disease in the LAD, followed by severe mid-segment disease at the bifurcation with severely calcified diagonal branch, followed by severely calcified diffuse distal LAD disease. The RCA was non-obstructive, but you can clearly see the calcium from the proximal to the mid segment, so it had mild disease from in the mid segment, which is severely calcified. One more incidental finding that you can see on this projection is the severely calcific aortic valve. So I proceeded with the PCI of the LAD, but the decision again was weighed. CABG versus PCI, the acute setting in the patient on dialysis, hemoglobin 8.7, creatinine 5.4. So PCI seemed to be the better option, so I went ahead, took an XB3 5 guiding catheter, took in a pilot 50, 0.014 pilot 50, 190 centimeters guide wire, and tried negotiating the lesion, but the lesion was not crossable. So what I did, I took another wire, and because of the path support of the guiding catheter, I parked the first wire in the OM branch to have some anchoring support, and then again took another pilot 50 with a single bend. It wouldn't go, so I took a balloon to a 20 balloon, and with the help of balloon tracking, I was finally able to find out the right trajectory and entered into the LAD. You can see here in subsequent picture. So after confirming that I was in the true lumen, the next step now was to predilate these calcified lesions. Because of non-availability of rota in this particular cath lab, I had to resort to different sizes of balloons. So first of all, I tried a 2.0, couldn't predilate the proximal lesions, so I took a 1.0 by 10, then 1.5 by 10, and then again 2.75 by 12 non-compliant balloon. And finally we got this result here. Tried to put in a stent wouldn't go down, so it finally decided to first of all stent the ostium and the proximal segment, which in the normal circumstance is absolutely an absurd idea, because the distal part of the vessel should always be stented first. But in this particular scenario, in which we did not have the rota or the any other open NC balloon or scoring balloon, so I just went ahead and nailed the ostium and just tried to save the side branch, that is circ in this case, and then open the LAD first. So acceptable results obtained, and then it was time to go and crunch the calcium in the mid-segment. Different balloons used. The stent again was not able to pass, so post-dilated the osteo proximal stent with a 3-5 balloon. And then I took a 275/16 ISR Neo Coroflex drug-eluting stent, overlapped in the mid-segment of the proximal stent, and then deployed that at 14 atmospheres. With the fear of renegotiating another non-compliant balloon, what I did, I just took this stent balloon and then post-dilated at very high pressures up to 22 atmospheres and went out and came out safely. So this was the result obtained. I couldn't do better than this in this particular scenario. You can see.